just let me know when you want me to start changing the slides.
Yep. Okay. So let's start. So this initiative about this protocol was an idea of Dr. Muravieva, Dr. Maria, one of the core faculty of the OB service. I'm so happy that she asked me about working with her, and I feel like this protocol, it was, a good experience for me. And I just wanna also say thank you to the fellow at that time, Dr. Mohammad Ali, that he helped me, and he was an important participant in developing this checklist. Next. So just a way to understand what is the importance of this protocol, we are gonna determine what is considered a definition of postpartum hemorrhage. So everything that is an accumulative blood loss or bleeding that is more than 1,000 mLs in the first 24 hours after delivery, regardless of the route, is considered a criteria. However, some institutions in some places depend if this is a C-section or a normal delivery, those numbers can change. But when you see signs of hypovolemia or things that tell you that the patient is unstable, you can start also with not having this exact number, 1,000, you can start determine or saying this might be a postpartum hemorrhage situation. So the CDC says the 700 women die annually due to these complications related to postpartum hemorrhage. And it's kind of like 11.2% of obstetric deaths in the United States. Next slide, please. So the ASA and the closed claim projects say that for all causes of hemorrhage, the obstetric hemorrhage account for 20% of those claims. And the factors they can, cause these claims are delay in the diagnosis of severe hemorrhage, delayed transfusion, and poor team communication. Next. So this is the most common causes of obstetric hemorrhage. We have here a normal placentation, like a number 1, and it's very common in our OB service. It's not something that we don't see. Actually, we see it kind of, once in a while, and we have to be prepared for these cases. And I feel that the core faculty that we have there always, all talk to us, and we have to be kind of ready when these cases arrive. However, you can have certain situations since like you are not sure about this, or the patient just comes in an emergency that I've seen in as well. So we have to be mindful of be prepared for these cases and other cases that can be associated with severe hemorrhage. We have placental abruption, severe preeclampsia, the other 2 more commons. And I can share my slides or the paper where I found these stats and give it to you guys if you want to go deep on this causes. Next, please. Next slide. Okay, the importance or the things that happen in the operating room are kind of sensitive because we have there the ability and the tools and resources to make these patients, be better and being able to get transfused in a timely fashion and don't delay this. So when we have this, we have to be very mindful about discussing with our obstetricians and the nursing staff where we are, and it's in our OB department, we always do that. We always are checking with them how we do it with the bleeding to decide what can be the next step, okay? Next slide, please. And a lot of institutions around United States, they have a group just dedicated to review these protocols and make sure that things are being done in the right way. And this is something that I feel that our institution is doing as well. And we just needed that part of developing this protocol in order to help new residents come into our service, like have something right away that they can see and they can just go through the protocols and make sure that all the standard care is being used for the patient that is experience this type of situations. Next. So this is the protocol that we develop. As you see, it's divided in certain segments. So before the patient arrival, open the patient arrival, if we are going to consider intubate this patient or not, the medications that we have to that we have available and we can use, and as well as management, and what is the target values for hemostasis when this is happening. Next. So here we just have like an idea of what to do before the patient gets to the OR. We have to review, obviously, past medical history, check our tools in the OR, make sure temperature is on the right setup, make sure that our airway equipment is available, and all the vasoactive or possible medications that we're going to use for the case are available. Next slide. So when the patient arrives to the OR, it's very important that we make sure that our access are present and we have fluids and make sure that the patient feel comfortable. We can use blankets, we can use a bear hugger. And this is kind of important in our institution. The number 4, that we have to contact our anesthesia tech if we're expecting or we see that our estimated bleeding is above 1,500, because we have to have available the ABG machine and certain things that we use in other trauma cases, like the Balaban infuser or the cell saver. And consider the use on arterial line if our estimated blood loss is above 2 liters. However, we don't want to say that this is like a set stone. If you see that your patient is getting unstable, you should discuss with your attending or the person that it's there, like, I think it's a good idea, just place an arterial line. This is more like a guide of all the things that should be in place when we are managing these acute cases. And also order a DIC panel and CVC stat. Next. So intubation, when we have these patients and they're unstable, something to consider. And in the OB service, our Pyxis machine has a section called C-section stat, and that give us important medications that we need to do RSI and intubate the patient in less than a minute. And so it's important that we know that this exists, because sometimes it can take a while, try to find the medications in the other drawers at that Pyxis. So that is an interesting thing. And when you open it or when you see the patient in the Pyxis, you always see in one of the corners that button, they say C-section stop button. If we're gonna intubate, we also follow, all the things that we do when we intubate a patient, make sure entitle is there and protective lung ventilation. So the concern about doing general anesthesia versus neuroaxial, I think it's always people prefer to do general anesthesia because the risk of having the sympathectomy and hypotension, and when a patient is bleeding, it's not a good idea. I just want to point that out. And also we have to do a careful induction, considering have available pressors and fluids, anything that we might need to resuscitate the patient. Next. Okay, this is an important part of our algorithm. So the use of these medications to increase the tone of the uterus are very important. We have Pitocin, Metergine, Hemabate. They are the most common use. Pitocin, we have the dosage there, and it's important that we can even bolus it. We can give less or the same amount of 3 units IV slowly over 30 seconds, and we can repeat it up to 3 times. And Metergine and Hemabate, consider give it intramuscular. These medications cannot be given intravenous, and consider the Metergine avoided in patients with hypertension, the Hemabate in patients with asthma. TXA is something that is part of the algorithm, is part of our protocol as well, and we can give 1 gram over 10 minutes, and we can repeat a second dose in 30 minutes, the same gram. The maximum dose, all the protocols out there established is 2 grams. Next, please. The activation of the massive transfusive protocol is important. The nurse help with that in the OB department, so we just need to request it and discuss it with them. And OB be present, or have present the use of cryoprecipitate. It's important. If we are transfusing, the goal or the idea that we have is like give 1 gram of calcium chloride every 3 units of blood products that we give. And for target values, and in those situations are keep our hemoglobin above 7, platelets above 100,000, and the fibrinogen above 200. So it's important that these protocols are out there. The American College of OBYNs have an established protocol. However, they do it kind of like a little bit different. They do it according to the amount of bleeding, and their organization is more like a stepwise. And when we discuss it with the core faculty of the OB department, they feel that our management is a little bit more dynamic, and this is what we decide to do in this way. If you find this protocol, it's kind of like the same thing. The only difference is that we're a little bit more like aggressive, I might say it, in our management. They sometimes wait a little bit to decide what to do when the patient is been bleeding more than 1,500. And I just want to point that out. And as a part of the protocol, they always include us in our in the management. If something happened, call anesthesia. So, we just wanna say that this protocol was meant to be done for the OR setting, and that was the original discussion. And next slide, please. And it will be available attached to the anesthesia machine in the ORs in the OB department. And if you guys have any questions, any suggestions about the protocol, I will be more than happy to answer them. Thank you.
Thanks, Karla. That was a great presentation. I think in the interest of time as well, we'll just move to the next presentation. If there are any questions for this one, please put them in the chat, and then we can bring them up towards the end as well. But that was fantastic. Thank you.
Thank you.
Nate, let's pull up the second QA presentation. And this one is going to be the checklist for suspected and confirmed malignant hyperthermia.
Just hold on here. My computer's giving me some issues, but I'll get it up here real shortly.
No problem.
All right, I think it's up there. Let me just start it from the beginning. Can everyone see that or not?
Yep. It shows up. And then just as a reminder, if any people have questions, if we have time towards the end of the presentation, we'll make sure to do them. And if not, please type them in the chat, and then we'll coordinate them with the presenters, either at the end of their presentation or at the end of our grand rounds today.
Thank you very much. I'm going to try to make the presentation succinct and digestible. Hopefully I can get through it quite quickly here. So my name is Katie. I'm one of the current CA2s. This project was for MH under coordination of Dr. Trout and the other group members, Zoe, Yashmi, and Ryne, who are also current CA2s. Next slide, please. So we had a lot of cases in Freighter specifically, as well as children's, for patients that were at risk for MH with family history and those that had suspected or confirmed MH in the past. With our population in Wisconsin, there are more frequent cases because we have a hub in a certain region of the state. So we do see them more frequently. We did not have a prior protocol for MH, so we wanted to create something that was easily digestible, easy to reference, and that was present in the main ORs. We started our project by surveying all the anesthesia personnel, asking them several questions, some of which highlight-wise I'll go through below. And then we afterwards created a checklist with all of the suggestions that were brought up, and we distributed them to IPP 16 through 47. The IPP 1 through 16 currently do not have these checklists. And then we also did distribute them to the OB suites as well on the 8th floor. Next page, please. So one of the first questions we wanted to really know, we've heard it was pretty common and we have personally experienced MH here at Freighter, but we wanted to ask everybody else what their experience has been. And over 70 people that responded to the survey said that it was a few times per year that they had seen MH, and very few had seen it more frequently, and some, less than 30, has seen it never. Next page, please. So first of all, we wanted to know if a resource would be helpful for MH or if it was something that was not going to be useful for the providers. Most people thought that it would be something that was useful, and treatment-wise, there is a full algorithm treatment that's present in the MH box that was well known by other providers as well. But we wanted to know if we had a quick reference for treatment, if that would be something that was useful until the MH box were to arrive in the room. Next page, please. And we also wanted to know, do providers actually know where the MH box is? Most people did know, but there was still around 40 people that responded to the survey that did not know where the box was. And this was just before we had done the MH drill with Dr. Pinkerton's guidance as well. So nobody had a refresher before then. Next page, please. And one of the other things that we were considering, there was a lot of different aspects to this project. We ended up just with the card itself in the ORs, but some of the other things that we were considering were things like identifying wristbands or hats that could really bring further attention. Obviously, as anesthesia providers, we already are aware of the patient risk of MH and we prep adequately, but this would be something that would be present for other providers in the room to be aware of the extra cares that is required for this kind of patient. Wristbands were brought up that things like the fall wristbands and DNR wristbands would be something that would be easy to do, but they could be easily cut off for IV access and might not be visible if the arms were tucked or if the patient was under a blanket. So we chose to omit that. And then special hats, like a bright orange hat that would be very visible to everybody else in the room, would just require special manufacturing that we were not going to pursue for the project. So we omitted that as well. Next page, please. So this is what we ended up with. This is the front page of the MH card. And if you haven't seen them yet, they are on the right side of the anesthesia machine in the main ORs. The front page of it really has the pertinent things for somebody that is first coming into the room. All of the things that most of you already do on a normal basis, but somebody that is first starting out in anesthesia, or students, or just somebody that hasn't experienced MH in a while, it's a good checklist to look at all of the things that must be done before the patient rolls into the room and when they roll into the room as well. And then on the right-hand side, we have the MH signs from most common to least common. common. The late signs are at the bottom in red. Obviously, things like DIC and myoglobinuria compared to the increased end-tidal CO2, which is what you would see most commonly. Next page, please. And I'm not sure if on the previous it was visible, the MH boxes are also listed on the bottom of the page. So you have an idea of wherever you are in the facility, you could have a note of where you could find the box. And then so on this back page here, this is something that you would just turn the card over in the ORs if you were suspecting that something was going on. Could it be MH? Could it be something else? And on here, we have some differential diagnoses that are common with some presenting signs. Not all of them obviously present exactly like MH, but if somebody is learning or somebody is concerned and not sure exactly what's going on, you could take a reference at all of these different pathologies. And they do have color coordinated circles on the left-hand side of some of the things, like increased end-tidal CO2 has the green, hyperthermia has the red. And on the previous page, we did have those common signs that also are color-coded. So you could just take a quick peruse around some of these differential diagnoses and see what actually matches up with you. And then the treatment algorithm is down below. We do have the mHouse hotline number as well, and that is something that needs to be called immediately. As soon as MH is recognized, you are going to have a lot of hands in the room. This is going to be an anesthesia emergency if it's a true MH that develops in the OR. So it's helpful to have, before the box comes, somebody take a look at this card and look at all of the steps that need to be done. Obviously, a lot of these are going to be started right away simultaneously, but this is just something that can be easily referenced on top of all of the things that you're already doing in the ORs to get you going to the right track for everything that needs to be done. Next page, please. So we rolled out these cards for several weeks and allowed the providers to take a look at them and use them. And then we surveyed the population again. And we wanted to know several things. Some of them, are the checklists easily actually to, are the checklists, do you know where the checklists are, and are they easy to follow? So most of the providers, 20 of them that replied to the survey, did know where the checklists are, and some still did not, perhaps those that maybe were not at the main hospitals and have not seen them. So again, they're on the side of each anesthesia machine and the main OR. And then we wanted to know if they were easily accessible, if people could readily reach them if they needed to, and they seem to be in a good spot for that as well. Next page, please. And if you remember on the prior survey, before we started the project, we had some providers that did not know where the MH box was in the past. And if you take a look at this result here, people that did not know in the past, about 18 of them, looks like maybe 17 or so, that responded to the survey now knew where the MH boxes were. And again, they are listed at the bottom of the front page. Some providers still did not know, others already knew, so they were already kind of aware of the things after the MH drill as well. Next page, please. And we wanted to know if the checklist we made was actually easily digestible, easy to follow, if the differential diagnoses were helpful, and overwhelmingly, everybody stated that most of the things were very useful on the checklist. Next page, please. And we did have a checklist. There is a lot of checklists available. There's a lot of resources online on treating MH. So we wanted to know, if this checklist was available in the ORs, are you actually going to be using it, or is it just something that's going to hang on the side of the machine and not be really that useful? And most people were going to use the checklist if it was available, which was awesome. If you had a case of acute MH in the OR, we also wanted to know if the treatment was useful or not, even though there is a full algorithm in the box. And most people did say that that was helpful. Next page, please. So overall, this project, we wanted to really make sure that we had a way for people to quickly reference MH treatment. We had a differential diagnosis and all of the preparatory steps that you should take a look at before you have an MH suspected patient or a confirmed MH patient entering your ORs, just to ensure that we have quality of care and a standardization of care for these patients. And it seems that with the interventions, it at least has been a useful aspect of the ORs that has been present. And we are running shorter on time, so I will take questions at the end of the presentation. Thank you very much for your time.
That was great, Katie. Thank you. And something nice for residents to kind of review for any upcoming boards, either oral or written, because that's definitely going to come up. I want to ask you one quick question, Katie, before we jump to the next presentation. On the initial survey that you sent out, it asked how often you encountered MH, and almost 70 people said a few times per year. So how do you interpret that in how often MH is actually occurring? Do you lead that interpretation in your survey that this is occurring up to like 70 times per year in our operating rooms?
I think with that initial questionnaire, it did ask providers whether it was confirming MH or suspected MH. So places like Children's, where they have a family history of MH, all of those providers are already taking that into account, and they're just treating the child as if they were already having MH if they were to expose them to a volatile anesthetic or succinylcholine. And actual MH patients, I think that was probably more rare, like a confirmed case. They've had it in the past. So I think this was just a generalization of those that are at risk and those that actually have had MH in the past.
Absolutely. And that makes sense. And when you survey a group of people that work together, when you survey one practice, if someone has MH and 20 providers come to help, then 20 people will say they saw it in the last year. It doesn't mean that there's 20 cases, so when you survey a big group like that, sometimes it may skew to make something appear much more common, whereas we know very likely that MH is not occurring 70 times a year in our operating room. No, that's an excellent answer. Thanks. So we'll go ahead and jump to the next presentation. If you don't mind pulling that up, Nate. Oh, excellent. This is going to be the RAPS thoracic epidural protocol.
Hi guys, my name's Saagar. I'm a CA2. I'm here to present our QI project. We just want to give a shout out to Dr. Weierthal. She has been a great help throughout the year as we got this project kind of moving forward. And then it's me, Mack, Nolan, and Jordan. Next slide, please. So the goal of the project was effectively to improve patient care and to decrease errors or near misses, while also helping teach newer residents and other consulting services about the appropriateness of our epidural protocol. As mentioned, there were some near misses that we had experienced over our time in residency that kind of inspired us to create this protocol. Stuff regarding anticoagulation, pending consults from other surgical services, pending imaging, and we'll kind of go into some of that right now. Next slide. So the first near miss, it was a 47-year-old male, came from the ED. After a fall, he had rib fractures. The SICU APPs consulted us for an epidural placement. We came bedside, placed it around 6 p.m. At 6:15, the APP told the patient's nurse that the patient actually needed to maintain strict flat bed rest and couldn't get sat up for that epidural per neurosurgery's request because the patient was going to go to surgery tomorrow. But unfortunately, at that time, the epidural was already placed because that was not communicated to us. Eventually, neurosurgery came bedside to consent the patient for their surgery the next day and placed orders for an MRI. And to make matters worse, the epidural that we placed wasn't MRI compatible, so it was removed. So that was just one example. Next slide.
Good morning, this is Nolan Asprey. I'll start off with the second case. So we had a 61-year-old female who presented to the hospital after she fell down a flight of stairs. She was initially diagnosed with L2 through 12 rib fractures, and the RAPS team was consulted for consideration of an epidural in this patient. The RAPS team assessed the patient in the SICU, talked with the patient, talked with the primary team, and ultimately deemed that the patient would be an appropriate epidural candidate. So we returned to the RAPS bay, collected all of our equipment, and then as soon as we had time to place the epidural, we returned to the SICU, and we were surprised to find that the patient was not in their room, and their bed was gone from the room as well. So we touched base with the primary team and were informed that the patient was actually having an MRI done, which had not been relayed to us. So it's easy to imagine that if the MRI were later in the day, or if the RAPS team had arrived slightly earlier to place this epidural, this would have been a case where a epidural had been placed in a patient who ultimately needed an MRI, and we did not have any intention of placing an MRI-safe epidural in this patient, since this was not relayed to us prior to we were going to perform the procedure. Next slide, please. So after reflecting on these cases, our group felt that there didn't seem to be a standardized approach to assessing trauma patients who were being considered for an epidural. And we identified that one of the ways which we could potentially make a difference and improve patient safety would be through creating a protocol to help with assessing these patients. We thought this would be especially useful for new learners. I know that some people individually may have an approach to assessing these patients, especially as they get more experience throughout residency. But a lot of times, somebody may be asked to assess one of these patients early on in training. We felt like having some of the do not miss things to look out for would be beneficial for these residents. So essentially, the things that we wanted to cover in this protocol were the assessment of the patient as far as medical history, medications, and any potential consults like neurosurge consults and imaging that may be remaining. We also wanted to discuss contraindications to epidurals or reasons not to have them placed, as well as anticoagulation guidelines and management, as these are especially important for neuraxial blocks. And then if the patient is deemed to be an appropriate candidate, we wanted to have a supply list for residents to reference, as well as some of the orders that need to be placed to actually obtain the medications for the infusion, and some of the common dosages that we use. And then, since this is also meant to be sort of an educational content as well, we just have some references towards the end of our protocol that provide some ideas as far as evaluating patients for uncontrolled pain, nausea, vomiting, hypotension, and things of that sort. Next slide, please. So as we approached this and created this guide, our goal was essentially to create a stepwise approach to evaluating epidural patients. The protocol starts with step 1 and basically finishes with step 12. And it basically walks through assessment of the patient, potential contraindications, where to gather the supplies, and all the way through placing the epidural. It's basically broken down steps 1 through 12. And then as you reach a step, such as, step 3, you should assess the patient for any contraindications. We added an appendix with a list of the potential contraindications and things to look out for and make sure you're not missing before proceeding. Some of those included an appendix for the equipment. Some of those include an appendix for the relative contraindications, and so on. And then we took it a step further, and we wanted to create a dot phrase. Any patients who were assessed by the RAPS team and were deemed not appropriate for an epidural, we created a dot phrase that gives you an easy way to place a note and explain the reason why this patient would not be receiving an epidural, potentially whether it could be done later, as far as timing of anticoagulation or follow-up from neurosurgery. And this was created into a dot phrase, which is under the dot phrase RAPS trauma epidural protocol. I think you can steal that from somebody on our team if you're looking for it. And then once completing the epidural protocol, basically identified which residents were on the RAPS service each block, as well as anyone who was covering night float during that 4-week period. And we've been emailing the protocol out to all of those residents at the beginning of the block and just saying, here's the protocol for reference. Please feel free to reference it during your rotation if you are assessing a patient for an epidural protocol. And then we also sent out pre and post surveys, which I think Mack will cover now.
Yeah, so looking at the initial responses to our preliminary pre-survey results, we had about 30 responses for this survey, and of those, looking at question 1, 41% said they had placed an epidural for a trauma patient. Then we have 4 questions that look at using a Likert scale look how comfortable residents are in ruling out thoracic epidural contraindications, managing the anticoagulation for epidurals, locating supplies, as well as managing complications. We see just, eyeballing here, there's a range of 5.14 to 6.83. So it's not that residents have no confidence, but we aren't terribly confident in managing the aspects of the thoracic epidural. And then as you look at question 6, 7, and 8, we ask, ASRA guidelines, where to find them? 83% said yes. What equipment is needed? 62% said yes. And then where to find those MRI-safe epidural catheters? 45% said yes. So decreasing knowledge about those aspects of epidurals. So based on those questions 2 through 8, we get the sense that there is probably room for improvement based on, or a need for a protocol to help educate residents, as well as to help improve patient safety. And that's sort of confirmed when you look at question 9, which asks our residents if they think that an epidural protocol would help with patient safety. And everyone in this, everyone that responded at that point had said, yes, they think so. So here we see that there probably is a need. So it's a good thing that we have initiated going through with this. Next slide, please. So as we move forward, we just want to continue to have residents check their emails, fill out our pre-survey as we send it out. Look over the thoracic epidural if you have time during your night float or RAPS rotation. Also, as we send out the post-survey project, the post-project survey, keep filling that out. It only takes a couple minutes, so we appreciate that. And then as we keep going, we'll continue to collect more data as residents have used the protocol and continue to assess, how well we've done at improving those sort of liker questions as well as overall resident knowledge. Next slide. So just some initial post-survey results for the 17 responses that we got so far. And again, it's not a terribly large population that's responded, so it's tough to say whether this is, related to any changes are related to a protocol or just a completely different response population. But at this point, in this second group, 53% had said that they had placed an epidural. We see some, equal changes in the ASRA guidelines knowledge, and then seemingly some improvements in knowledge about what equipment is needed and where the MRI-safe catheters are. Interestingly, less people thought the protocol would be needed in the post-survey response. So must be maybe a different population there or something else going on. But next slide. And then as we look more importantly at the Likert scale questions, we see that in each of the groups, we saw some increase. Did not do any statistical analysis to see if there's any change there that's statistical, but or significant. But we do see that there is an increase based on residents' comfortability in this post-survey. But again, as we move forward, collecting more data, seeing if this is truly related to our protocol and seeing the effectiveness and how well we're actually educating residents and improving patient safety moving forward. Next slide. Any questions?
That was great. Thank you, guys. I have a quick question about the project in general. So this is a really excellent way to kind of see if you can mitigate any concerns with neuraxial procedures where very small things can lead to pretty catastrophic patient outcomes if it isn't really caught by all of the groups. And this is a wonderful way for our team to be a little bit more aware. If you think of quality improvement from an entire systems-based perspective, the next step may be starting to think, in trauma patients, what information can we offer the trauma team so that it isn't missed from their side as well? So if this project was going to be continued to extend, if you were going to take this out from now, this information is given to the team that's doing the procedure, what information do we give to the team that's requesting the procedure? How would you see an extension of this to the trauma team?
I think that one of the biggest things that we noticed when we were looking at these cases is that a lot of times it's timing of things and just communication between the teams. So if we're notified that an MRI is going to be planned, we can place epidural or MRI safe epidurals. It's just that we need to be aware that those things are planned. I also think that if the primary team is aware of potential contraindications, anticoagulation status, future imaging, consults that are to be done or pending, just them being aware that those things can affect timing of placement would potentially help with A, discussions, and then B, consulting the RAPS team at the appropriate time as well. So I think that, I don't know if there would be some sort of meeting that we could join with them, or even just provide them with a handout, or even just access to the protocol that we have, which lists the contraindications. I think that would be a good starting point, and then just touching base with them to see if there's other things we could do that would be helpful.
Yeah, just to echo what Nolan said, I think having some sort of like expectation from like the trauma team as far as information we need to be able to safely do the block, because a lot of this sometimes happens at like 3 a.m. when, you know, there's like only residents in-house that are covering, you know, the OR and their like floor service. So maybe it's hard to get everyone to communicate effectively immediately, but if they know what we are looking for, can have it ready for us, we can respond, you know, appropriately and probably more quickly.
Thanks. There's another question in the chat. Is there a location in the LDA associated with the epidural catheter as to whether or not the catheter is MRI compatible? And if that's true, is this visible to the MRI personnel? Are you guys aware of that?
I believe that when you place the epidural, there is a button for the type of catheter. I think most of the time it's like MRI conditional versus MRI safe. I know that we have both catheters in the hospital. Generally, we're placing the MRI conditional catheter. So I believe that it is a button that can be filled out when the epidural is placed. Whether every single person pushes that button, I'm not quite sure.
Thanks. If there are any other questions that come in the chat, we'll see if we can get them towards the end of grand rounds. But that was excellent. Thank you, guys. Let's go to our fourth presentation, which is going to be Andy Vega, who's presenting about improving the rate of preoperative prophylactic antibiotics in colorectal surgery patients.
All right, good morning, all. You guys know me, so today I'm going to be talking about my QI project. We already mentioned the title, but before starting, I wanted to thank you all for making this possible, because I know like you guys were key to implementing these changes, even maybe not without, you know, knowing it, just because we're in direct contact and we're the ones that end up giving the antibiotics in the OR. So to start off the presentation, I wanted to provide you an outline of what to expect. You can, next slide. So background, aim statement, methods, which include the lean analysis and also Fisher exact test, results, conclusion, and future goals and references. Okay. So a little bit of the background, we decided to make this QI project because it's known that colon SSIs are a major source of morbidity in colorectal surgeries. And there's like multiple studies / programs in place surrounding this topic. A little bit more about the background. Okay, next slide, sorry. It's known that the correct timing of IV antibiotics should ideally be administered within 60 minutes, and that correct selection would have to include like gram-negative and anaerobic coverage for the gut microbiome. And we found this topic, of course, to be great of importance, because improving this compliance in this metric will one, improve the care provided to our patients, two, reduce the hospital length of stay, reduce costs, and of course, like if there's an additional infection, they might have to go back in, and also, so that includes another procedure for our patient. And if we're successful on making this change and improving, then there's potential for this to expand to other surgical teams and departments and even locations. Next slide. So this brings us to our problem. We looked at the correct selection and timing of antibiotics from January 2022 to August 2022. And when looking at the previous data, our rates were only 31%. And this is 31% saying we correctly selected the antibiotic and we gave it on time. Then we analyze also like them individually. Given this problem, we decided to evaluate our EPIC, PAR, OR, workflow, and everything in between. And our aim was to improve our rates to more than 75% within the Freighter system. Next slide, please. The methods already mentioned before, but to correctly determine where this problem lied, we went with a lean analysis, which involved evaluating the order sets, the administration of the antibiotics, and all the steps in between to identify areas of improvement. We chose this method because it just allows us to kind of take out wasteful steps in creating a new process and just taking the steps that we would think that would actually solve the issue. And at the moment, we wouldn't know until we saw the implementation and then look at the rates. And let's say if those steps that we took did not improve, then we'd go back to the whole lean analysis and try to figure out another maybe rate limiting step. Next slide, please. So essentially, all of these members that are on the bottom, operations coordinator, infectious disease, colorectal surgeon, residents, APPs, all of our people, it was a huge group. It was pretty fun. We sat in a big conference and we just all discussed and we gathered insight from everyone of like, where do we think the problem lies? Even included EVS, even included the transport people. And after much debate, discussion, we chose key limiting steps, and we created a new process that would hopefully optimize efficiency and compliance with antibiotic timing and choice. So this is essentially what we're doing, is determining the potential areas, identifying potential solutions, implementing them, and then monitoring them. Next slide, please. And our QI project yielded these results. A total of 719 cases were evaluated. And this graph on the right shows the date on the x-axis and the compliance on the y-axis. So for example, in the month of February 2022, we correctly selected and administered the antibiotic in time 40% of the times. And then throughout the year, then we just take a mean and it was about 36%. And then after our implementation, the whole mean was about 74%. So before our QI project, our highest compliance was about 60%, and post-implementation, our highest rate was 90%, with a mean of 74%. Remember, our goal was 75% or more, and so it was officially, our goal was officially not achieved. Next slide. Although when using the Fisher exact test, it showed that our improvement rates were statistically significant compared to our previous rates. We had improved in the timing and selection, which was our primary goal, which we already discussed. Then we evaluated just the timing alone, the ordering antibiotics more than 48 hours before surgery, and then actually using colorectal surgery order set, which was previously designed, but curiously, like nobody was using them. So after our QI project, we determined these were steps that were easy fixes, and we'd just essentially evaluate if this would improve our rates. And to put this into perspective, the bottom row, where it says median, it shows that antibiotic timing went from finishing antibiotics 4 minutes late from incision to finishing antibiotics early by 38 minutes, which I think is a huge improvement. And this was also statistically significant. You can go to the next slide. So just to conclude, we improved in most of the fields by more than 25% and almost achieved our goal of 75% compliance in such a short period. So I'm sure if we just continue to pursue this endeavor, we'll be able to reach our goal. Next slide. And talking about goals, our future goals are to further just analyze our data with more stringent criteria / CPT codes. And this is just to determine if there's any improvement in the surgical site infections in colorectal surgeries at greater. And then once we reach our goal of 75%, then we'll be able to incorporate this QI project, like I mentioned before, into other specialties or even like freighter locations. Next slide, which is just the references. So thank you all for your time.
Thanks for that impressive presentation. I had a question about the results slide. When you showed after the implementation of the QI project that there was an improvement, I mean, almost immediately, I'm just looking at it on my other screen, of the timing of antibiotics. What intervention do you think was most impactful into leading to that very like acute, within a month almost, improvement of administration?
Yeah, I think now all the teams were a little bit more aware, and to be honest, just the fact that we all sat together and people from all the teams, from PAR, from pre-op, from PAC, from all of them, I think just everyone was a little bit more aware. And a big thing I think for me, that I think helped a lot was actually starting some of these antibiotics even in the pre-op area. So at least we would get that rolling, and if they weren't started, they were at least hung on the little patient stand. And then people, again, it's a visual cue of, hey, these are the antibiotics, and we had to administer them. Which in the past, I remember just being forgotten. Oh, the orders weren't ordered by the surgical team. That's why we included one of like the things that we evaluated was ordering the antibiotics 40 hours before the incision. So there was a lot of miscommunication between all the teams, and everyone was kind of pointing at each other at one point. And then I think just everyone being on the same page and having a clear goal, I think essentially just all added up.
You collected a fair amount of data too. What was the hardest data do you think to actually like obtain accurately for all of this?
I had a lot of help from the statistical team, and I think the hardest part of the data was trying to select like the correct coding for each of the cases, because our surgical team has their kind of little coding thing, and then we have the NISQIP coding, and that starts getting messy, and that's why we have a little big circle over here, I think in the results area, that says like all qualifying CRS, and then after that we just keep on dividing and subdividing. So I think definitely that was like the most difficult part. It starts getting messy and trying to determine which fall into our group study.
Thanks for a great presentation.
Thank you, Dr.
We'll jump to the last one now, which is going to be about CPAP use in the PACU.
Thank you guys for listening to this presentation. I'll try to make it a little quick because I know some people have some cases to start. We wanted to first thank Dr. Castro for mentoring us through this presentation. I hope you guys enjoy it. Next slide, please. So I don't think it's a shocker here, especially for the patients we take care of at Freighter, that they're not the healthiest people in the world, especially with our increasing morbidly obese population, our patient population that has a moderate to severe obstructive sleep apnea. I think one of the things that, of course, that you're taught as an early stage one, as an early anesthesia provider, is that, you know, if somebody has severe obstructive sleep apnea, somebody's at risk of severe postoperative respiratory obstruction, that, you know, we encourage our patients to bring CPAPs, BiPAPs, use the hospitals. But we never realized that there is a great way to really implement that workflow into both the extubation to positive pressure or rescue measures in the PACU in case someone has a respiratory event. Really, we identified three major problems in that sort of workflow, and that was assembling and troubleshooting hospital machines, especially figuring out where the availability is, who to involve and who to call. You know, who do we call for this? Are we allowed as providers to assemble machines ourselves? What if we need to get a hold of RT and they're not available? How do we get a hold of RT and things like that? And then again, the third thing, which I previously mentioned, was how do we get machines in the operating room and in the PACU? Next slide, please. So we sent out our initial needs assessment that included both use of hospital and home CPAP and BiPAP questions, which really showed that about 34% of anesthesia providers said that they felt confident in calling RT to help with setting up CPAP or BiPAP. We found that only about 30% of survey responders said that they felt confident or somewhat confident in troubleshooting a hospital CPAP or BiPAP. And 73% of respondents said that they would be interested in some sort of training course at the end in order to really figure out how to assemble these. Next slide, please. So our intervention was actually fairly simple, but we thought was rather informative. We actually went ahead and created, with the help of our RT colleagues, to make an informational sheet that's been uploaded to C8 The first outlines how to get a hold of respiratory therapy, whether that's in the PACU or going straight to the operating room, and then how to actually assemble and troubleshoot a hospital CPAP or BiPAP machine. Even though all of our CPAPs and BiPAPs, if you call the respiratory therapist at Freighter, they come pre-assembled. Sometimes in the PACU, they do not. Or sometimes if you're the PACU resident taking care of a patient who has been extubated to positive pressure, you do have to troubleshoot some monitors and alarms, especially if the respiratory therapist are, off in other ICUs. So we thought that this would be a useful handout that's pretty easily accessible for everyone. Next slide, please. So impacts of intervention will be the next 3 slides. Really, after our discussions with the respiratory therapist and feedback from our initial needs assessment, for our post-intervention survey, we decided to kind of take out the element of using patient CPAPs and BiPAPs due to the just inherent difference in nature of multiple machines, having to figure out the nuances of different things. What happens, if the machine breaks, are you liable for that? There were a whole lot of there's a lot of gray area that we decided to just get rid of and focus on just using hospital CPAP and BiPAP. So after we sent out the survey, it was really nice to hear that we had a 94% response rate and saying that people felt very confident in being able to figure out how to call respiratory therapy for help, either with rescue positive pressure therapy or with helping to facilitate extubation of positive pressure therapy. Next slide, please. So our second question was how confident we were as providers to be able to assemble a hospital CPAP or BiPAP in the case that RT was not available. And the large overwhelming majority said that people were either extremely or somewhat confident in just being able to review the handout and trying to figure out how to assemble one of those machines. Next slide, please. And then again, really, the third question kind of addressed how comfort in troubleshooting a hospital CPAP or BiPAP. This one was not unexpected and people still feeling a little bit uncomfortable. I think that as anesthesia providers, we have basic knowledge about, minute ventilation, what's an appropriate respiratory rate, settings, and things like that. But I think that trying to really figure out how to troubleshoot a machine you're not super familiar with, unlike the anesthesia machine, is still a little bit daunting. Which kind of brings me back to our point that we made in our pre-intervention survey with the overwhelming majority of people wanting to go ahead and have a sort of informal training session, or we could make it formal, about how to assemble the CPAP and BiPAP machines. So next slide, please. The really nice thing that we enjoyed about this project was that it really provides a nice springboard for future projects and ideas about how to further integrate the respiratory therapist into our workflow, or allowing the anesthesia providers to really take over that workflow depending on what we think would be beneficial both for the patient and both as separate departments. I think we really outlined 3 major goals that we wanted to have for this sort of project if people were to take it on to the future. The first one really being a very simple, having a formal training session, whether that's, we have RT come for a resident half day, or they're able to hold a training session in the PACU for our CRNA and CAA colleagues. The second was really having more CPAP and BiPAP machines available. I know that in the PACU that there is one permanent machine that lives there, but sometimes you do have multiple patients who are requiring and necessitating positive pressure interventions, whether that's due to post-obstructive respiratory depression, whether that's due to positive pressure salvage therapy to bridge to reintubation, things like that. And sometimes when RTs aren't available, we don't really have access to additional CPAPs and BiPAPs. And then I think the third more longitudinal goal of this project was to actually go ahead and be able to identify those patients who are at high risk of postoperative respiratory obstruction, whether that's due to their medical history, morbidity, body habitus, or the nature of the procedure, a combination of all of those things. Having them be seen through a high-risk anesthesia evaluation and being able to just kind of put a flag in their chart to know that these patients are at high risk, and being able to have a hospital CPAP or BiPAP machine readily available in the operating room in case that need to extubate to positive pressure becomes apparent, without really having to call anybody. I know that project would probably take a fair amount of work, but that's probably what would be the ultimate goal of this project. With that, we'll take any questions. Thank you.
I'm glad you put up a slide about kind of future goals and the ultimate goal of this project itself, and where the direction that this could go. One quick question I have, and I know we're moving towards the end here, is that when you implement these QI projects, if this was going to be implemented at like a hospital-wide scale, you'd want to intervene and be looking at kind of a change in something. What would be your ideal data points that you would evaluate before implementing this project and seeing the outcome after implementing this project?
So I think ultimately what we would like to go ahead and achieve and really look at from that sort of perspective would be, but I think what we would mainly want to go ahead and look at is people's comfort in being able to kind of integrate that sort of workflow that we uploaded to with that worksheet, and really just kind of assessing post-survey whether or not us as anesthesia providers, again, felt confident in, with or without the assistance of our RT colleagues, being able to extubate somebody successfully to positive pressure. So I guess if you want to look for hard data points, you're probably looking at rate of success of extubation to positive pressure successfully, if that makes sense.
Absolutely, yeah. So those are then the questions ultimately, is saying if you would like your anesthesia colleagues to be more familiar with this, what is the reason for that, right? Is it successful extubation to BiPAP? Is it a decreased rate of hypoxia in a certain time frame? Is it a decreased rate of post-operative pneumonias? I mean, that would then be the next question, is how do you show to the system, to the hospital system, that you've led to an improvement in patient care? And so exactly, that would be the data point you could pick, but then ultimately you would try and find something concrete that you could show, look, by intervening and training our anesthesia colleagues, we're able to impact this kind of factor in patient outcome.
Yeah, I think really the easiest point would probably be to look at decreasing the amount of like respiratory events, especially in our post-anesthesia care unit, and then kind of extrapolating from there, like you were saying, Dr. Kappas.
Excellent. Well, thank you so much. I know everyone's kind of going off to their first cases already, but thank you to all the residents who presented. The rest of the residents will present next week. These were really fantastic projects. Great job, everyone.